Our aim is to provide top educational content and awareness about fatty liver disease to healthcare professionals, patients, and their families. Today, we are honored to have Dr. Vamsidhar Reddy, consultant hepatobiliary pancreatologist and liver transplant physician from Chennai, as a guest speaker. He has been trained in diagnostic and therapeutic upper gastrointestinal colonoscopy and ERCP procedures. We are grateful for his dedication to improving liver health. And without further delay, I would like to invite Dr. Vamsidhar to share his valuable insights on management of MASLD and MASH. Over to you, sir.
The outset, I thanks the Zydus Group for giving this opportunity for having public awareness on MASH. And second, I will bring in warm welcome from the Apollo Hospital, Chennai. Uh, can you go to the next slide? So today my talk is to have a brief awareness regarding the emerging pandemic is fatty liver. So that too on metabolic dysfunction associated fatty liver disease. So as you know from introduction, this liver is second largest organ, which is on average around 1.5 kilos, and which is located in the right upper abdomen. So which generally it will be in that pinkish brown color, soft consistency, and this is generally vascular, like a goat meat, what you see, goat liver. So it will be the same. Uh, but this is also called as the powerhouse. So powerhouse because it has more than 500 functions in the body. So that so it's a very important vital organ. Next slide. So as I told, there's a 500 more than 500 functions. The most important functions I'll just note it down. So it is mainly helpful in the metabolism, both for the metabolism of the digested food and also helps in regulating the blood products. Basically, like it promotes the coagulation, produces the coagulation factors, and it also helps in the processing of nutrients and also helps in the storage of the vitamins. And the other main function is that detoxifies the blood. So and it also produces bile, which is helpful in the digestion of the food products. So next slide. So previously we call as a non-alcoholic fatty liver disease, and due to some disadvantages in the name like stigma and proper diagnosis of exclusion, so it has been recently within last 2 to 3 years it has been changed to MASLD, which is metabolic dysfunction associated steatoliver liver disease, which is an umbrella of diseases which comprise like when there is a fat deposition in the hepatocytes is more than 5%, then which is not majorly by the alcohol other causes, then we can label it as a metabolic dysfunction associated liver disease, which is associated with some metabolic factors like diabetes, hypertension, hypercholesterolemia, and also hyperlipidemia. And some patient females like in hypothyroidism or PCOS, they're also having this metabolic dysfunction. The fatty liver is associated with these risk factors, excluding the alcohol and other diseases, then we can label it as a MASLD. Next slide. So if you see this, 1 out of 4 people, now it has increased to 1 out of 3 people in the recent data consists from India. So 1 out of 3 people having the fatty liver regardless of the weight. And if you see the diabetics, it is almost 6 out of 10 diabetics, they have a fatty liver, almost 60 to 70%. In the severe obesity people, is almost 90% have a fatty liver. The male gender has a more risk factor compared to the female gender, and this is not in a single disease, but it's as per se it is in a spectrum of disease, because a patient can start from simple MASLD, they can go into MASH, that is called metabolic dysfunction associated steatohepatitis, and the further if it progresses can go into fibrosis and cirrhosis and the end stage liver disease. Next slide. So as I told, this is a spectrum of disease. It's not a simple disease per se. So from the healthy liver, if you see in the left hand side is a healthy liver that looks like a pinkish brown in color, which is turned into the fatty liver. That means slightly the fat droplets will deposit in within the hepatocytes, which are the cells which is present in the liver. And if it's more than 5%, then the more than 20, around 15 to 20%, then ultrasound will pick up. So that is a common finding. People will note like they will go for any some other investigation to have a routine checkup or some other disease. They will be doing an ultrasound. So they find incidentally to have a fatty liver if this is more than 15 to 20% of cells get accumulated by the fat. So if this further progresses, there will be a stage called hepatitis, and which will further progress into fibrosis and then cirrhosis. And next slide. So, what is the difference between MASLD and MASH? So, MASLD is a simple fat accumulation in the liver. That means that fat, whatever extra fat, whatever the body produces, that will be accumulated within the liver. So, if you see the left-hand side is called steatosis. That means the fat droplets will just sit within the hepatocytes. The right side diagram we show it is called an MASH. MASH includes steatohepatitis and also fibrosis. What will happen is the cells will get enter into the hepatocytes due to the metabolic factors, whatever what they're having the risk factors, and also the patient's immunity, and also there will be formation of free oxygen radicals, which will damage the liver cells. So further, and there will be development of insulin resistance, which will all this have a cascade they will be developing, and then there will be cells will get ruptured, and then the if you see in the liver function test, SGOT, SGPT parameters will be elevated. And if the system goes like that, then if they're not reducing the risk factors, then they can develop scarring. This complete stage is called MASH. So once they cross the MASH, the reversibility will be lesser. But if your patients come with steatosis or MASH, if they reduce the risk factors, they can be completely reversible. Next slide. So what are the risk factors I told already? So it's a mainly obesity, metabolic dysfunction, and these are the risk factors. So the obesity, diabetes, hypertension, dyslipidemia, all these things. The root cause is insulin resistance, which can occur due to the overweight or obesity. So this overweight and obesity can occur can be due to genetic background or excessive calorie intake or in a physical inactivity or being exposed to some medicines or like a metabolic syndrome, which includes diabetes, hypertension, and dyslipidemia. Next slide. So obesity, so that is a root cause. So what will happen is if there's an increased obesity, the whatever that there is in the tummy or central obesity, which will in turn lead to fatty liver, and which in turn lead to MASH and scarring of the liver. Next slide. So diabetes always is almost threefold increase in the because in a MASLD, what is the main problem is it's the non-liver related mortality will be higher as you continue with these risk factors. There will be almost the threefold increase in the death due to cirrhosis. If there's a patient is having a diabetes along with this like if the patient of MASLD goes into cirrhosis, the patient has a diabetes, there will be increased risk, and it's a vice versa. If the patient has a MASLD, there will be high prevalence of diabetes, 2 to 4 fold of increase in the risk of developing of diabetes. Next slide. So symptoms, generally 70 to 80% of patients will not have any symptoms at all. The only the 10, maybe they generally find it when they go for a routine health checkup incidentally when they go for an ultrasound or in a liver function test. If they do, they'll have the slight rise in the liver enzymes, and then further workup they will have this fatty liver being diagnosed. So the other 10 to 20% who develop symptoms, there will be some vague abdominal pain in the right upper abdomen, and there was if the patient progresses, means that the patient have MASLD is progressing to cirrhosis, then the patient will have jaundice and confusion, and which is called hepatic encephalopathy, or there will be enlarged blood vessels in the esophagus, which is called food pipe. So there will be bleeding of vomiting. There is a bleeding from the vomiting. And there may be bleeding from the when they pass stools also. So these can happen. The patient can also develop some malaise, extreme fatigue, and nausea can also happen if this associated with the fatty liver or MASLD or MASH. Next slide. So the diagnosis generally it is called a silent killer because the 90% of patients will not, 80 to 90% will not have any symptoms. But this can even go for a progress of disease which is very gradual, so that patient will not have any symptoms. That's why early detection and going to the hepatologist or liver healthcare provider will be the ideal situation. Which patients require medications, which patients will not require medications, what are the things we need to be, what are the warning symptoms we need to know. All these things we can able to find from the healthcare provider. So the diagnosis involves mainly from the generally most of the people get from the ultrasound, and some blood tests will be doing, so like liver function test and PTNR and CBC to know the stage of the liver disease also. And very rarely in these the research oriented centers we can go ahead with the liver biopsy. Generally, liver biopsy is not required. And if the further there is a doubt that there is something coexisting pathologies or some cirrhosis in a daily daily stage between fibrosis and cirrhosis, then maybe we'll require an CT and MRI. And there's a new like investigation which has come, which is non-invasive investigation, which has a high negative predictive value and also and a decent positive predictive value is a fibroscan that I'll be mentioning the next slide. Sir. Next slide. So the most common blood test we generally all over the world we generally is the liver function test, and there are some we can also do along with the hepatitis B and hepatitis C to rule out like other viral disease can cause fatty liver, so that we can rule out. And the third thing we can just ask on the history itself whether the alcohol intake is whether it's crossing the safe limits or within the safe limits or not. So the most common blood test we do see in the liver function is SGOT, SGPT. There will be elevated ALT will be there. So elevated AST can be there. Most probably the ALT will be elevated. But there's no definite cutoff for the ALT, which can progress for to MASH or advanced fibrosis. Anything more than 1.5 times it is elevated and than the normal, we have to think it is a major thing, and then we have to go to nearby hepatologist or liver healthcare provider. Next slide. So what are the blood tests what we use? I mean, so based on the blood test, what are the scoring methods what we use is the most commonly we use in the OPD practice is the FIB-4 score. It's simple like calculation like age, AHT, ALT, and platelet count. We have a mobile calculator or we can have to see, and then we have to calculate the score. And there is one more score called the NAFLD fibrosis score: age, AHT, ALT, and platelet count, and BMI, and fasting glucose and albumin. There are some other online tools like Agile Score, which includes the FibroScan also is there. But the most commonly we generally we use in the is the FIB-4 score to know whether the patient is having a patient having the early stages of fatty liver or late stages. So that we need to know. So next slide. So what are the non-invasive diagnosis? I told the problem is there is easily available the main pros are this like easily available, it's a very economic and reason for most accidental diagnosis of MASLD. So we can able to pick up early itself. The only the cons is if the fat is more than 20-25% only, then only we'll detect the ultrasound the fatty liver, and it cannot differentiate between fat and fibrosis. Sometimes may not be differentiating. So for that we need an other investigation called fibroscan, which is helpful. Next slide. So this fibroscan, which can even diagnose with there's at least 10% of fat, it can differentiate between fibrous and fat content, and it's easy to operate. So the in that picture, if you can see the right side is a 5.2, the value is there, that will denote the liver stiffness, and there is a blue color thing is a 198, that is the CAP score, coefficient attenuation parameter, which will at least this is not a gold standard for fatty liver estimation. At least you will know about what is the quantification of the fatty liver. And what is a what is a cons in fibroscan is if the patient are obese or patient having ascites or patient has to be in fasting, so then the patient will have there will be some errors in the values. Otherwise, it's a decent high negative predictive value is there, so that patients we can fatty liver can get utilized uh, not as screening, at least to further prognosticate the fatty liver. So we can use fibroscan as a diagnostic tool. Next slide. So and this is the how we will. This is a portable fibroscan, and some hospitals they have a means it is non-portable fibroscan also will be there. So as I told, they will be seeing LSM, that's a liver stiffness measurement, and CAP, that is control attenuation parameter. Next slide. So there's a what is the point? We will only just fibroscan. The only problem is we will only just point out some different 10 different points, and we'll get an average score. But MRI PDFF, which we use generally in the research categories of hospitals. So what will it will completely estimate whole liver, basically what is the fatty liver fat content in the liver. So it is a gold standard to detect fat content, and the fat content more than even more than 1% also to detect. But this is only generally we tend to use for the liver transplant donors basically, because we have to prognosticate prior only to whether we are when you are giving the as a donor to the recipient, but it's not widely available in all centers and it's costly also. So it's generally reserved for this research purposes, and some hospitals they are using the routinely also. But for health liver donors, we routinely use MRI PDFF for estimation of the fat within the liver. Next slide. So liver biopsy again, it's a gold standard, but only thing there was some because of the way when we point out when we take in a biopsy, basically there may be maybe no fatty liver also, because because this is a whole liver, we'll only see one by one 10,000 part of the liver. So maybe it is gold standard. If we find it, if not, we have to go for other scans also. So only method to diagnose the MASH, because we can able to see the inflammation within the biopsy, and we can able to rule out other diseases like Wilson's, autoimmune hepatitis, or wild hepatitis. We can rule out by doing a when there is a concomitant etiology are there. But only thing, side effects are painful. It is invasive procedure, and chances of misdiagnosis will be there in very early stage, because we'll only take 1,000 1 by 1 lakh 110,000 part of the sample. So and it is individual dependent. So we should be taking care of a comprehensive manner when we are diagnosing fat liver for the patient. Next slide. So what is the natural history of fatty liver? So once we diagnose fatty liver, basically some patients can progress to fatty liver with mild inflammation, that we call as a MASH. So almost 20 to 25% patients can progress into MASH. In that 20 to 25%, maybe over 15 years, some around 10 to 15% can go into cirrhosis if the risk factors has not been controlled over the time. And cirrhosis can develop into HCC in around 7% of the patients. Maybe around in that to 20 in that whatever patient who develop cirrhosis, 20% can develop 20 to 30% can develop decompensations. The main risk is the non-liver related deaths are more common, like cardiovascular malignancies. The third most common is the liver related mortality. So that's why this is completely a metabolic spectrum rather than the liver related mortality, which will occur in the late stage of liver disease due to the fatty liver. Next slide. So, and act before it's too late is an apt quotation. So, because generally fatty liver people take it as a very light thing, but we should be, as you go to the healthcare provider hepatologist, so they will be telling you the prognostication and also risk factors what is associated with it. So, they may lead to almost in 15%, they may lead to progression of the liver disease. At that time, maybe the things what we say it is reversible, fatty liver may not be reversible, and they have a cardiovascular mortality rate will be very higher compared to the liver mortality rate, liver related mortal deaths basically. And what is the treatment? So the first treatment what we tell in OPD or is the mainly is a weight reduction. So that is the main culprit, and also the concomitant risk factors. What is there like diabetes, hypertension should be under control. So the weight reduction so can be done by either by diet, exercises, or lifestyle modifications. Some patients we can use the new medications that are coming into the market. So we can use new medications which can able to reverse the fibrosis, and also reduce the inflammation and reduce the fatty liver content in the liver. So some patients may require the medications. Most of the patients they may reverse if they come in early stage. They may reverse with diet, exercise, and lifestyle modifications. Next slide. So what is the control weight gain? Basically, it's a hypocaloric diet. It should be a combination. It's not be only one option. If you take, it will be difficult. So it's like a hypocaloric diet you have to take, and the moderate to intense exercise you should do. And weight loss, at least 3 to 5% of body weight will help in steatosis. 7 to 10% if you do, it will even reverse the MASH also. So and including fibrosis. But once it's cirrhosis, the definition says it's irreversible. So we have to find the cases and educate the patients and give awareness in the initial stage, like either in MASLD or in a MASH, rather than going to the fibrosis and cirrhosis. Next slide. So I have already told this is steatosis, around 3% loss. The steatosis will go, and if in histology, if you do a biopsy, balloon inflammation will go more than 5% will reverse. And NASH resolution can occur if it's more than 7%. Fibrosis resolution can occur if it's more than 10% of weight loss is there. And this is the only proven uh, therapy for the fatty liver. The other medications which has proven effects that I will be coming to the later slides. Next slide. So, and the most common diet, what we tell to is Mediterranean diet. This is the one which, but some patients, this is like a pyramid which have a green leafy vegetables at the bottom, and the high calorie meat like red meat and sweets will be in the top of the pyramid. And mm, uh, and weekly portions like eggs, cheese, and yogurt can be taken weekly. And oil, generally the recommended oil is the olive oil. So that this is what the Mediterranean diet is there. So there will be we'll be reducing the carbohydrate contents as much as possible, and maybe we'll be increasing the protein content in the diet. So that's what is called a hypocaloric diet. Next slide. So exercises, both aerobic and resistance exercise, anything can be done, but only thing patient at least has to do 45 minutes, 40 to 45 minutes per day. So every day they have to do, and so that they burn the calories and reduce the weight. Next slide. So lifestyle tips basically is the main. Avoid the sedentary lifestyle, avoid the junk foods, get enough sleep, and regular medical health checks, and eat small and frequent amount of meals, and lower your sugar, high calorie intake. So all these things can help in a long run for the fatty liver reversal. Next slide. So pharmacological approach, there's only some molecules which has been recommended in India. The most common molecule is vitamin E and salmeterol. So what has been recommended? The INASL is the Society for the Liver in India, in Indian National Association for Study of Liver. So what they recommend is it's a vitamin E with or without omega-3 fatty acids. We can give for the patients of fatty liver at least for 2 years in a non-diabetic adults and pediatric patients. If the patient had diabetic and in the, both diabetic and non-diabetic patients, if the patient having a with or without fibrosis, then we can add as a co-drug salmeterol, or we can give only salmeterol for at least 1 year. We should give as according to the current society guidelines. Next slide. So tips are already there. Limit the intake of saturated fatty acids. Eat a balanced diet. Limit the consumption of refined carbohydrates. Maintain a healthy weight. Take the medication as prescribed. Limit or avoid alcohol intake. Exercise regularly, and quit smoking as much as possible. And alcohol also, I have to limit or avoid alcohol to prevent the fatty liver disease. So, I thank Jairus for giving this opportunity again for getting awareness to the public. So, fatty liver, always remember this is a very silent killer. So, we should be evaluated for fatty liver disease and meet an hepatologist before further going for any medications or any other pharmacological therapies. It is always better to meet a hepatologist prior to taking the medications. Thank you.
Yes, thank you so much, sir. Now, sir, we have received a few questions from audience. So, shall we start, sir?
Yeah, yeah.
So, sir, how common MASLD and MASH in Indian population?
How common is?
MASLD and MASH in Indian population.
Recent studies says almost one in three people. That means that if you have India, 150 crores are there. So almost like one in three means it will almost like out of 50 crores of people are suffering for MASH, basically MASH or MASLD, whatever is it.
Oh,
It's a huge prevalence is there.
right. And sir, what is the ideal diet recommendation for MSLD patient?
Ideal is we have to tell the patients low calorie, low carbohydrate, means low calorie diet that can be achieved by low carbohydrate and low fat diet. Protein they can take according to the weight basis only. The main thing is we have to take small food intervals in a frequent intervals. If they have a diabetes, we have to be taking a diabetes diet also. So, but generally we have to take a low calorie diet, which includes a low fat and low carbohydrate diet. So, and we have to reduce, generally normal Indian adult will have 2200 kilocalories per day. We have to reduce at least 500 kilocalories per day. So that it should be, we have to have a diet of 1500 kilocalories per day with around 1 kg, 1 milligram per, 1 gram per kg per body weight protein we can take. So if you take a 60 or 65 kilo adult, if we take, so their calorie intake should be 1400 to 1500 kilocalories with a protein intake of 65 grams of protein intake should be there.
Okay. So what kind of exercise will you recommend for MSLD patients?
Actually, both aerobic and resistant exercise can be done, but mainly patient need to sweat basically, and they have to listen to their heart rate. So they have to get they need some time to sit. Basically, that is how we need to do exercise. 40 to 45 minutes. Moderate exercise are okay for the patients in a patients of fatty liver to reduce that target of 7 to 10% of body weight. The patient having a MASLD or MASH.
All right, sir. So now on behalf of Nash 24 by 7, I extend my sincere thanks to Dr. Vamsidhar for such an enlightening talk. Sir's insight have highlighted the need for increasing awareness about fatty liver disease. I also want to express my appreciation to our audience for their active participation. Please stay connected with Nash 24 by 7 on Facebook page for more updates and information. Take care, stay well. Thank you so much, sir, for joining us today. Thank you.
Okay. Thank you. Thank you.